Welcome back to part 3 of trauma. Part 3, we're going to talk about trauma triage. This is not your mass casualty scenario. This is who goes to a trauma center, who goes to level 1s, level 2s, level 3s, level 4s, 5s, and then your veterinary clinics. So let's talk about this a little bit. Trauma triage, and this is a quote, injury is the leading cause of death for persons aged 1 to 44 years in the US. 1 American about every 3 minutes dies from trauma. So CDC is the one who puts out these recommendations because trauma is an illness, is the way they look at it. I know CDC's been a little busy the last year with COVID, but trauma continues. And they look at this through 4 aspects: physiologic criteria, anatomic, mechanism of injury, and then special considerations. So let's talk about the definitions of anatomy and physiology. Anatomy is the structure of the body. Anatomy is, the bones, the skin, the vasculature, the muscles, the heart, liver, kidneys, lungs, etc. Physiology is how those are working. Pathophysiology is how they're failing to work, basically. It's what we're worried about. So the most important thing when you look at assessing your trauma patient is how's the body responding to this injury? How's it working? Is it compensating? Is it not compensating? Okay, and so we look at that first. Then we look, what are the obvious injuries that we can tell, or what are the suspected injuries that we are thinking about? Then mechanism of injury, then special considerations. So trauma centers and their levels. Excuse me. This is always one of those things that confuses people. When you are in a state like Maine, New Hampshire, or Vermont, our choices are fairly small. In New Hampshire, we have 1 level 1 trauma center, Dartmouth up in Lebanon. Maine Medical, level 1. Fletcher, Allen, and Burlington, I don't know if there are 1 or 2. But then you look at the city of Boston, and there's, I don't know, 6 or 7 of them, some silly number like that. But so, yeah, that's great. You're in the city of Boston, and you have a gunshot wound. You call CMed on the radio and say, hey, ambulance 1 with a status 1 trauma patient gunshot wound. They will tell you what hospital you're going to, because they keep track of the numbers of who got the last trauma patient. So Brigham's just got a trauma patient, now Mass General's up, so you're going there. It's not that easy for us. If you call for a helicopter, they'll take them to the appropriate place. But if we're going by ground, what is the appropriate place? So let's look at that for a minute. Now, American Academy of Surgeons and the CDC also says that a level 1 is a comprehensive resource, regional resource, with tertiary care that can provide total care for every aspect, from prevention through rehab. So part of their outreach, their community outreach, is injury and trauma prevention. It's like Shriners Burn Center in Boston. They do a huge amount of burn prevention, okay? Do you see in the state of New Hampshire, and I'm not picking on any one hospital, I'll pick on everybody equally, but whether it's Parkland and Derry or Wentworth Douglas and Dover, do you see them doing a lot of community trauma prevention? I don't, okay? So level 1, prevention through rehab. Elements of that, they have 24-hour in-house coverage by everybody. Look at that list. Okay, regular surgeons, neurosurgeons, plastic surgeons, maxillofacial surgeons, vascular surgeons, okay, as well as, your anesthesiology and your ER folks and x-ray, okay? Now, they are also a referral source for communities in nearby regions. So if you have a critical access hospital like Huggins and Wolfboro, you can call Dartmouth and say, hey, I need a trauma review, a trauma referral. and they'll speak to the trauma surgeon on call and say, hey, this is what I got. My surgeon's saying no, or I don't have a surgeon on call tonight. What do you think? Yeah, send him here, or no, he could go to Portsmouth, okay? Leadership in prevention and public education. Continuing ed for those trauma team members. In order to get certified as a level 1, level 2, level 3, whatnot, there's a lot of training and scenarios that go on so that everybody knows exactly what their role is. And when I say what their role is, this provider stands here. This person stands there. This person does this. There's no bleacher fans yelling stuff out. It's the surgeon talks, everybody listens, okay? If the surgeon gives an order to the med nurse acknowledges the order, repeats the order back, and does it, okay? If you walk in with EMS, excuse me, to Portsmouth ER, which is a level 2, you're going to give report to the trauma surgeon. And that trauma surgeon does not want anybody talking but the one giving report, period. Your partner is trying to get the patient unbuckled and is talking to one of the other staff members about how to help move them, and they'll tell them to shut up, okay? Maybe politely the first time, but one person talks at a time so that everybody hears what's going on, okay? Comprehensive QI program, teaching and research efforts. You know, they look at what they're doing for care, and is there a way they can make it better? Substance abuse screening, and then they have to have a minimum number of trauma patients. Excuse me. One of the flight medics that used to be at Dartmouth that I know told me that the only reason Dartmouth's a level 1 volume-wise is because of their helicopters. Their helicopters bring them enough trauma to meet that minimum number, which is either 1,000 or 1,200 patients. I don't remember exactly. But otherwise, they'd be a level 2. They have everything else, right? Dartmouth is a teaching hospital. They have Dartmouth Medical Center and Dartmouth Medical College, right? So they have all that there, but without that, the helicopters being a regional resource for all of New Hampshire and most of Vermont, they wouldn't have the numbers. I think when Portsmouth went through theirs for a level 2, I had their EMS coordinator come in and do a training for me at Exeter Hospital. And I think he said for Portsmouth level 2, it's 100 patients. And they expect within those 100 trauma team patients, there's a minimum number of over triages. In other words, well, we called this a trauma activation. Turned out he didn't need it, but that's okay. A certain percentage of them needed to do that to prove that they are not missing some, okay? So level 2, excuse me, definitive care for all injured patients. They have 24-hour immediate coverage, not in-house. So some of these folks might be on call from home, but they're within a, I don't know, let's say 15 or 20 minute callback, okay? Most of them stay in-house though. Tertiary care needs cardiac surgery. They can do dialysis and vascular surgery. They can refer those out to a level 1, but they can do everything else, okay? Trauma prevention, Con Ed, and comprehensive quality assessment program. Those things right there set the difference between a level 1 and a 2. The numbers and that total care. Because I've seen level 2, like Portsmouth, ship things out for rehab that Dartmouth would have held on to, okay? Now, level 3 has a demonstrated an ability to provide prompt assessment, resuscitation, and surgery care of injured patients. They have immediate coverage by ER docs and prompt availability of general surgeons and anesthesiologists. So this is kind of old school ER. Everybody came to your local ER and your anesthesiologist and surgeon when they got around to it, would show up and take him to the OR and take out his spleen. Okay, but they send their more comprehensive patients to a level 1 or a level 2. All right. You know, Parkland in Derry and Portsmouth in Portsmouth are both HCA hospitals here in New Hampshire. Portsmouth's a level 2, Parkland's I believe it's a 3, and they'll send patients back and forth. You know, Parkland will send some trauma patients to Portsmouth. They also will send them into Boston to a level 1. Okay. They do provide Con Ed and continuing education, and they are involved with prevention, which is great. Oh, excuse me. Level 4s, they can provide some stabilization prior to transport. Okay, so their ER docs are supposed to have advanced trauma life support. Okay, 24-hour lab capabilities. Not everybody has lab in-house at night. Not everybody has respiratory therapy in-house at night. Not everybody has x-ray capabilities in-house at night. It's 2021, and if you think I'm pulling your leg, I'm sorry, but I'm not lying to you. I've worked in the recent past at 2 critical access hospitals, you know, both Huggins and Memorial, North Conway and Wolfboro, and they have to call people in sometimes at night. It may not be where you want to take your trauma patient. So let's look at this list. This list is a year old. I don't believe it's changed any in the last year. And what you'll see is it says, oh, adult trauma, pediatric trauma. Then it lists cath lab and stroke. So Alice Peck Day, they are not a designated trauma center. And in the state of New Hampshire, trauma center designation is voluntary. There's a lot of money involved in doing this, a lot of training, a lot of QI to prove why they can do this, why they should do it, and then getting inspected and licensed to do this. There's a lot of money in it, and there's not a lot of money in trauma. I can't remember where I read this, but the majority of trauma patients are uninsured. I mean, in the state of New Hampshire, there's no insurance requirement for motor vehicles. Okay, so a lot of our trauma is uninsured. So Alice Peck Day and Androscoggin, nope. Catholic Medical Center is a 3 for adults, a 4 for pediatrics. Cheshire, which is in Keene, Cheshire is part of the Dartmouth family now. They're a 3 and a 4. Concord, 2 for adults, and they do a good job with adults. I've never taken a kid in there, but their trauma team does a good job. It's a level 2, they should, but they're a 3 for kids. Cottage are 4s. Dartmouth is a 1 for adults. They're only a level 2 for kids, though. Elliott is a 3 and a 3. Exeter, undesignated. When I left there in 2015 as you know, after being their educator and a paramedic, and at that time they wanted nothing to do with trauma care. Again, it's expensive. I've heard over the last year or 2 that they're talking about possibly going towards for level 3. But it's finances. Portsmouth with their standalone ER in Seabrook is taking, you know, money from them, and Portsmouth Hospital is getting a lot of trauma patients. So, you know, I've heard they're looking at that. Franklin, Frisbee is part of HCA now, undesignated. Huggins, critical access, they have no interest in it. Well, their EMS coordinator would like to, but their surgeons don't want any part. LRGH is lucky they're still open, right? They're going through bankruptcy, undesignated. Littleton, Memorial in North Conway, Monadnock in Peterborough, New London, undesignated. Now, New London is part of the Dartmouth family, and I worked for them for 3 or 4 years, and they have their own transporting service. And our trauma went to either Concord or Dartmouth. If you were south of exit 12, you went to Concord. If you were north of exit 12, you went to Dartmouth. And, you know, you could be on the highway 2 miles from New London, you're still going to one of those 2 places. You might be out at Sunapee ski area and you got a 45-minute ride. You're going to Dartmouth. Okay. Portsmouth is a 2 for adults and a 4 for kids. Southern New Hampshire, 3 and 3. Spear and Plymouth, undesignated. St. Joe's and Nashua. So In Nashville, you've got 2 level 3 trauma centers because they're competing with each other. And then you can see the rest. And Wentworth Douglas is a 3 and a 3. Now, let's go look at this whole cath lab thing though, right? So we've got a ton of undesignated trauma centers. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 undesignated trauma centers. But for cath lab, so we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 that hold some form of designation. Our trauma center, our cath labs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Stroke centers, 1, 2, 3, 4, 5, 6, 7, 8, 9. So trauma, level 1 and level 2s, we only have 3 level 1 or level 2s, but we've got 10 cath labs and 9 stroke centers. Why? There's more money in cath labs. There's more money in stroke centers, or less expense to be a stroke center, because you can have your telemedicine, do your online stroke assessment. And I think that number's gone up, by the way, on stroke centers, because I know now Memorial and Huggins does stroke care. They do telestroke, and then they ship the patients out after they get their meds. So, but there's more money in it. There's less outlay of money in it. Trauma is very expensive. So let's look at this. When we look at it on a map, I got X's for undesignated, red 2s, blue 3s, this is all adults, and then black 1s. In the state of New Hampshire, if you fall inside of this red line, which is the majority, you are screwed when you dump your motorcycle. You are screwed when you get shot, or when you crash your car, or when you get run over in a parking lot. Okay. The state of New Hampshire, the majority is urban, is rural. Just, you don't have this care. You're going to have an hour ride to a trauma center by ambulance. You're going to have an hour and a half ride. You're going to have a 40-minute helicopter ride, whatever it might be. Okay. Now, this is a list of a patient that I did a transfer on going to rehab from a level 2 trauma center. And this was their most significantly injured patient at the time. And look at this list of injuries: sternal fractures, pneumomediastinum. So the mediastinum had a hole and air in it. Bilateral hemopneumos, multiple displaced ribs, bilateral pulmonary contusions with acute respiratory failure. That's a shock. Left distal fibulars, lumbar spine, shoulders, pelvis. The bladder was ruptured. Pelvis was mush. Traumatic cardiac arrest in-house. Anyways, diabetic because of it. Got 40 units of blood in the first 24 hours. But there was no evidence of head injury. This was a level 2 trauma center, and this guy did great. I took him out, talking, stable, happy to be alive. This was Portsmouth Hospital. I'd have no issue taking a patient to a level 2 trauma center. If I can drive to a level 2 before I can get a helicopter and they can get to a level 1, guess what? I'm putting them in my truck and I'm heading for a level 2. I've taken patients to Portsmouth from Tamworth, New Hampshire, Northern Ossipee, Tamworth line. 55, 60-minute ride by ground. They did not need a helicopter, but even if I got a helicopter, it was going to be a half hour for the helicopter, and then they were going to be on scene for 20 minutes, and then a half-hour flight someplace. So for an hour and 20 minutes to get to a level 1 by air, 55 minutes, I was at this level 2. So I got no issue with that. Now, our state protocols, we've been updated in 2020, but the trauma designation stuff has not changed. So let's look at this. Because one of the arguments people go is, well, we got to go to Huggins because it's the closest hospital. Bullshit. No, you don't. Well, from that scene in Ossipee, I was 30-something minutes to Huggins. on back-ass nasty roads. And I was 55 minutes going down Route 16, including some highway, to Portsmouth. And between Ossipee and Portsmouth Hospital, I had a ER in Rochester that had RSI certified paramedics. I had an ER at Wentworth Douglas, a level 3 trauma center. I had a standalone ER owned by Portsmouth in the city of Dover on and off ramp of the Spalding Turnpike. And then I had Portsmouth Hospital. I had all kinds of help if I needed it. So do I sit there and wait for a helicopter? No. And it was only an extra 20 minutes to Portsmouth. So why would I take somebody to a critical access hospital where they're not going to do anything that I can't do right now for this patient, and take them, let's take them to the trauma center. So the protocol, vital signs, level of consciousness. This is that physiological heading that the CDC says. So what's their coma score? If it's less than 13, they go to the trauma center, right? Yes, if feasible, level 1 or level 2 by ground or air. If it's not feasible, then you go to the closest other trauma center. So you go to a level 1 or 2 if it's feasible. Level 1 or 2 is not feasible, you go to a 3 or 4. Systolic blood and a coma scale of 13 is they're just a little goofy. This is not anything, you know, a less than or equal to 13. They're just a little goofy. Systolic blood pressure less than 90 or signs of shock. What are some other signs of shock, right? Tachycardia, tachypnea, pale and sweaty, right? They're shutting down blood flow to their skin. They're shunting blood to their main organs. That is a sign of shock. Tachycardia is a sign of compensated shock with a normal blood pressure. Tachypnea is a sign of compensation with normal vital signs, okay? You know, cap refill less than 2, that's a sign of shock. They go to a trauma center. They don't have to have a blood pressure less than 90. They can be in compensated shock with a pressure of 124/80. They go to a freaking trauma center. Yes, I get pretty I get pretty wound up about this. Respiratory rate, less than 10 or greater than 29. This was something that floored me when I had Grant Turpin was the EMS coordinator at the time for Portsmouth. As I said, I had him come in and do a monthly Con Ed for me at Exeter. And he said that as part of their review of trauma patients, in order to be certified as a level 2, they had to look at all trauma deaths over the previous 2 years. Every single fatality at Portsmouth Hospital, every single dead trauma patient had a respiratory rate that was less than 10 or greater than 29. Wow. So yeah, you see those respiratory rates, they go to a trauma center. Now, okay, he's got a broken ankle and he's hyperventilating and having a panic attack. Well, if you can slow his respiratory rate down just by talking to him and by splinting his leg and his pain gets better, he doesn't need to go to a trauma center. Greater than 29, less than 10, or if you're bagging them. And if their respiratory rate is less than 20 in an infant, remember an infant is less than a year old, you go to a trauma center. Now, if physiologically all those things are no, now we look at anatomy. I'm not saying we don't look at anatomy in our assessment, I'm just saying in our decision making. If they have any of those things in physiology, yeah, they go to a trauma center. If the answer is no, Glasgow's 15, their blood pressure is 142/70, their pulse is 88 regular and strong, and they're not pale and sweaty, respiratory rate's 16, SATs are great. Okay, now we look at anatomy. Penetrating injuries, basically from the knees and elbows in and up. Head, neck, chest, belly, pelvis, thighs, biceps, upper arms, right? Because those are where the big vessels lie, okay? Chest wall instability, they got a full chest, boom, yes, trauma center. 2 or more proximal long bone fractures. Remember the terms proximal and distal. Distal long bones, tibia, fibula, tib fib. Well, you break your lower leg, a lot of times you break both of them together. That doesn't count. The vessels that go with your tibia and fibula are not typically going to kill you, and they're easier to control, right? You can put a tourniquet on above the knee and control that hemorrhage. All right, so 2 more proximal. So femurs, humeruses. Any extremity that's crushed, degloved, mangled, or pulseless. Amputations above the wrist or ankle. Hey, hands and feet, okay, but we can control that and keep them alive. Any pelvic fracture. Now, how do we assess a pelvis? We take our hands on both sides of the pelvis, and we push down and in with gentle pressure. And if there's any instability or they go, ow, we're done. They have a broken pelvis, okay? The other thing, just below where your belt would be, if you push towards their bladder, you'll feel a bone, symphysis pubis. If that is mushy, that's a pelvic fracture. Off they go. Any skull fracture, any paralysis. Answer is yes, they go to a trauma center. If the answer to that is no, now we look at our mechanism of injury. Falls for adults, 20 feet, right? That's 2 stories. At 10 to 20 feet though, well, damn, what did they land on? Did they go 20 feet onto the grass and it's May and it's been raining for 3 days and it's muddy and soft? Or did they go, 15 feet onto cement? So that one, that's a little open translation. But kids more than 10 feet. High risk auto crash. Now, mind you, you see this number 20 miles an hour, that's for an adult or a pedestrian that gets hit, thrown from or run over by a car. Motorcycles over 20. Now, high risk auto crashes, you'll notice there's no speed there, okay? Motorcycles, bicycles, and pedestrians don't have protective cylinders around them. So that's why there is a low speed associated with that. But high risk auto crash, if the roof comes in more than 12 inches, if any intrusion comes in, including the roof, so the door or the roof more than 12 inches where the person is sitting, boom. 18 inches any place else, they go to a trauma center. Does not matter what their vital signs are, does not matter what their injuries are. If that roof's come in more than 12 inches over them, they go to a trauma center. If they get ejected, either completely or partially, or if in that same passenger compartment there is a death, they go to a trauma center, okay? Now, special considerations. When we talked about CNS and traumatic brain injuries, we talked about older adults. So in this, right, risk of injury or death increases after the age of 55. I turned 55 yesterday. Swell. There is a higher risk of injury and death because we don't compensate as well, and we have higher comorbidities. We have blood pressure, high blood pressure. We take blood pressure meds that don't let us compensate. We have COPD and emphysema, which don't let us compensate, okay? Over the age of 65, when we look at blood pressure, it's not 90, let's look at 110, okay? And those low mechanism injuries, those ground falls, they bang their heads, right? And they have atrophy, they're at more risk for head bleeds. Kids should go to a pediatric capable trauma center. Burns, if they have trauma mechanism, trauma injuries, they go to a trauma center and then they get moved to a burn center. But if you have no other traumatic mechanism, there was a flash of a campfire, a water heater let go, and it's water burns, or a water heater flashed, the gas leak flashed, and they got burned only, they go to a burn center. There are no burn centers in New Hampshire, they need to go to Mass General. Portland does some burn stuff. And if you're a kid, you should go to Shriners under the age of 18. The best burn care in the world, and it's free. They should go to Shriners, okay? Pregnancy over 20 weeks, you should consider taking them to a trauma center. And then the one I like at the bottom, everything else is normal. Everything else is negative. But you're just looking at this guy going, I don't know. Take him to a trauma center. Now, everybody else can go to the closest appropriate acute care hospital, okay? Now, if they code, if you think they're about to code, or you need an airway that you can't do, then yeah, maybe you've got to go to the closest hospital. But otherwise, they should go to a trauma center. Now, Portsmouth has their trauma sheet, and on it, it lists, is this patient on blood thinners? So keep that in mind. Blood thinners, put that underneath the whole special consideration thing, okay? So those are the patients and the decision making that we need to think about next time we're out on the side of the road. Don't take your patient to the closest hospital because they're 2 miles away. Some of these hospitals don't do a very good job of trauma. They sit on them. They do 17 x-rays and 5 CAT scans, and that takes time. They pump them full of fluids, which kills them, okay? And then they still have to get a trauma center to accept that patient. Then they have to wait for an ambulance to come do the transfer. It's a lot of waiting for a trauma patient, okay? So pick the right hospital every time. Take your trauma patient to that hospital. Okay, so we're going to move on to part 4 here in a minute, which is basically the history and the theory behind tourniquets and hemostatics.